What's up everyone, Ian and Dr. Loc here in Pasadena, California. We're going to go through a conversation about integrating a few different things that I've been seeing him do at a high level. Really excited about today's content, so let's get right into it. One of the first things that we're going to do is kind of in general define some of the systems that you guys might not have heard about. So I'll turn it over to him. Why don't we start off with, everybody's heard how I feel about FRS, so why don't you just start off with a brief outline of what FRS is to you.
So FRS to me is the complete system of optimizing joint health. Their perspective is to look at any given joint, major joint in the human body, and make it work as well as possible. And in their definition, that's with the biggest, cleanest cars and with minimal active to passive ratio deficits and no closing angle pain for what that person wants to do. It's incredibly brilliant because they're just able to simplify it for both user and operator, the trainer, clinician, as well as the client patient.
Well said. So next one that we wanted to kind of talk about is PRI, which is the Postural Restoration Institute. So what would you say about that in terms of a general description?
The Postural Restoration Institute basically takes into consideration our natural asymmetries and ultimately its effect on the autonomic nervous system. They would like to manage these possible compensation mechanisms, ultimately to get someone to be able to move relatively evenly through both sides of their body.
Awesome. And I think, one of the major things that we were talking about before is the idea that the role of the diaphragm is very, very crucial within PRI, right?
Absolutely. So within PRI, they've got these different, what they call polyarticular chains. The two major ones that most people will, with an understanding of PRI, will understand is the right BC pattern, which is the right brachial chain pattern, and the left AIC pattern, which is the left anterior chain pattern, both of which start at the diaphragm.
The next big one that we wanted to talk about was DNS, so Dynamic Neuromuscular Stabilization. So why don't you go ahead and tell us just a little bit about that?
Sure. DNS talks about the developmental sequences that all humans go through, and from the clinical application of it, they want to be able to get people to understand and appreciate how to use their diaphragm for both its respiratory and also postural functions, and then use that to integrate with these positions for optimizing movement.
Awesome. Okay, so there's a good little kind of introduction to those three. Now let's get into more of the specifics. What are some of the ways that you've been successful using and integrating these systems?
So I'm still in the process of learning the three systems and getting better at all three. At some point, hopefully, I'll figure out when is the best tool to pull out of the toolbox. But effectively, people who come in here, they all can use FRS to some degree. They can all use PRI to some degree, and then they all can use some DNS to some degree. The question then becomes which is the optimal sequence of implementation based on how the person's presenting. But for the most part, when someone comes to me with a complaint, during the course of their evaluation, their history and their subjective complaints are really going to give me an idea as to where I might want to look first. But whether they choose to go through a full FRA or not, I will put them through a quote-unquote mini FRA of that particular given joint, and maybe the neighboring structures, one above, one below, just to see if there are any contributing factors. The PRI objective tests, I can knock them all out in under 10 minutes, and that will give me an idea as to where they might be from a PRI perspective. And then within DNS, I'm looking primarily at the at the DNS IAP tests, and that's going to take me less than 5 minutes. And so between those three, if I get something that really stands out, then that's really what I'm going to go after. But with that being said, the FRS activities, the FRC work, specifically cars and pails and things of that sort, that's really easy to prescribe and to achieve compliance with, because it's so simple to effectively say, hey, this is what we're doing, this is how you're going to do it. Whereas the other approaches, there's a little more work that goes into explaining how you're going to do something properly.
Well said. So one of the things that I find coming up more and more with my practice and a lot of the people that I've talked to, learned from, is there is no absolutes, but in certain circumstances, there's really things that come up very commonly that we really use consistently. So one of the things, for example, would be we find a lot of people that don't have hip IR or shoulder IR, and they end up using the sleeper, and you'll have 10 people that you might see, and a lot of them are going to find that entry level of how to start working on IR. Is there anything across those three systems that is similar to that, maybe even more specific to PRI and DNS, that you find yourself really using very consistently with almost everybody?
I would say that given our current modern lifestyle, most people that come in here are pretty sympathetically driven, and so whether or not they've been able to figure out a way to manage it through other means, the other things they're doing in their life to offset it, will really dictate where we're going to start. So across the board, I find that people really don't know how to exhale, and people don't know how to properly integrate the postural function of the diaphragm. And so we'll typically spend a few minutes working on that and getting them to understand that, like, hey, like, breathing is non-negotiable. If you're going to breathe, you have to do it better than what you're currently doing.
Love it. Couldn't agree more. What do you think about actually taking us through maybe the breathing sequence that you're talking about, or is that with the belt?
I can definitely take you through the breathing sequence.
Like, how would you assess breathing? Maybe that would be a good thing to go
No, of course. Perfect. So you can go ahead and have a seat. I'll go ahead and show this. You're going to have a seat right here. So what I'm going to do is I'm going to do a quick assessment of Ian's ability to utilize his diaphragm for postural or stabilization purposes. So I'm going to come off here. So as you can feel, Ian, I'm on your abdominal wall here. You feel my fingers here. Without using your breath, can you gently push my fingers away? Okay, you're having a hard time finding that.
Yeah.
Right?
Yeah, I wanted to breathe. I was like, oh, I got you.
Yeah. Okay, so can you feel how this ab wall, its passive features are a little less stiff than this one? Yeah?
Yeah.
Okay, so now I'm going to move over here. And once again, do you feel my fingers?
Yep.
Okay, once again, without using your breath, can you push my fingers away? Okay, so you found it, but do you feel how shaky the quality of motion was?
Yeah, for sure.
And you're having a hard time talking and doing it as well, right?
Definitely.
Yeah. Okay. So then we're going to go ahead and move to the front. And so do you feel my thumbs?
Yeah.
Okay, once again, you're not allowed to use your breath. Go ahead and push away without. Okay. So right away we can see that Ian tries the strategy of like sucking in his belly, right? So.
Boy's getting fat. It's been a tough trip.
Okay.
Sorry.
That's
Get back
okay.
to the clinical.
So go ahead and come on, give me a little expansion here. Push into my thumbs. Push my thumbs away. There we go. So you can get there, it's just hard for you.
It sure is.
Okay, great. Go ahead and relax.
I definitely do the opposite.
Yeah, you suck in, you
To
pull
use
everything
my-
out.
Yeah, and then just try to get long. That's really what I'm going with. And then I'll fill up after.
Right. Yeah, so right now you're basically
Like that?
conflating the two, right? Postural versus respiration.
This is good.
This is the 3-month developmental or triple flexion test. where we're going to have you here. Go ahead and relax for me. So I've got you here, okay? And you ready to take this over from me?
Hold, like pass the range hold?
Well, what I'm going to do is I'm going to let go of your legs. You got to hold this up on your own. Okay, you ready? And here we go. Okay, so right off the bat, I'm just looking at how he strategizes to stabilize himself. As we can see, his belly button actually just kind of flipped up towards him. So we know that he's got more pull of the superior fibers of rectus abdominis against no pull of lower fibers of rectus abdominis, but we don't really want rectus abdominis in this instance here. And as we're here, we can see that you're just puffing, you're extending, right? And so tell me, where do you feel yourself working? What's holding you up?
I definitely feel a pull in.
Okay.
Like that's definitely my strategy, without a doubt. I guess I can feel a little bit of that crunch that you're talking about.
Right. What else do you feel? I mean, you're using your neck, that's quite obvious.
Yeah.
I mean, those guys are on, right?
Yeah, I guess that's not super definitive. Floor.
Okay.
Like almost like a gentle push of the sacrum into the table.
Okay, great. So, so believe it or not, like in this test, what we're looking for, what we would consider ideal or optimal, is that you just feel like a 360-degree cylinder here just working to hold you up. In a lot of people who don't have good IAP, they're going to feel lots of hip flexors, quads, hamstrings, adductors, whatever it is that they're going to use to support themselves. Okay? They'll feel neck. They'll feel their back extensors kick in, right? So, and it's just, everyone has a different strategy as to what they think they should be doing versus also what's easy for them to achieve.
And pushing out is definitely the best. I mean, I guess it depends on the person, but like pushing out would be a much better cue than pulling in, because that's obviously not working for me.
I don't like pushing out. I just like to use the term expansion, right? So if you
Without breath though, because that's the first
breath.
time I've heard that.
Yeah, because what happens is that your diaphragm descends both in postural function as well as in respiratory function. And what we're trying to get you to do is understand that one is not the other. Okay.
That makes sense.
Cool?
Yeah. So then what would be my my intervention?
So in your intervention, I mean, I could you know, try to do some cueing and manual techniques and things of that sort. But that's where the brilliance of the core belt comes in, right? The core belt's a real easy tactile cue that lets the person feel what it is we're trying to feel. And if you'd like, we can go through that right now.
Yeah, let's do it.
Yeah, please, let's have you sit up. So let me have you strap that on, nice and snug in the front. I just don't want it on rectus. I don't want it on paraspinals. We can think of it as like the corners, northeast, southwest, the diagonals. Cool?
And the top is like basically right at the bottom of the rib cage.
Yeah, we don't want you to hit ribs, right? Cool?
Yeah.
So let's have you go ahead and lay back down again. So here we've got a Core 360 belt, and don't do anything just yet. So I've got you here. And all I want you to do once again is you feel the belt, right? So in a 360-degree manner, I want you to just gently push the belt away. Don't have to kill it. Okay, so you feel that nice expansion all throughout. Give me a little bit of pelvic right there. Perfect. Keep that expansion. Okay, you ready to take over?
Yeah.
Okay, and put your hands by your side. Just go and relax. And here we go.
So I want you to practice leaning forward there. I'm going to use the restroom real quick, and then we're going to get going.
Okay. So you're still allowed to breathe, right? It's just what I want you to do is not let your postural function disappear with your exhale. Can you feel that now?
So maintain the pressure out as I exhale.
Yes. So you've created some pressure, right, just from the postural function of the diaphragm. When you inhale, it's going to increase even more because the diaphragm's further descending. And then when you exhale, this is the training. So how does that feel now?
Definitely feels like work. I definitely feel better areas working for sure.
Can you feel what your neck is doing or what it's not doing now?
Yeah.
It's not holding you up.
It's definitely more relaxed for sure, and I definitely feel the work in the midline.
Right. Do you feel your hip flexors? No. Wild, right?
Yeah, it is pretty wild. That's good.
Cool.
Yeah, I like that.
Right. So then all we're hoping then is, obviously when people are doing very specific block training with their core belt, that they really tune into what that feels like. And then of course they can absolutely use the belt when they do their other activities. I love getting people to do this with all their cars. Yeah. Cars with a core belt and cars without the core belt are two completely different experiences.
Yeah. That makes a lot of sense.
Okay.
You can really lose it.
Yeah.
Yeah. I like that. That's good. I definitely need to get one.
We now have an OmTrack sensor where we can, if we find that you have an area in your ab wall that doesn't work so well, we actually have a sensor.
Can feel the pressure of it.
And an iPad that actually, an app that actually shows how much you're keeping your pressure.
Yeah, it's tough, man. The exhale to pull out. I'm so used to filling up.
Yep.
And then just relying on that pressure right there to keep me out in every direction.
Right.
Which is just a different strategy, not necessarily a bad strategy, but I definitely need the first one.
Right.
Yeah.
Yeah. It's just like anything else. You want to be able to, you want to be able to do stuff, right? It's the same thing when people come in and they can't move their toes during tow cars. It's like, well, yeah, you should be able to move stuff, right?
Yeah.
It's like you shouldn't say hey, that's okay, right?
So where would this approach feed in with PRI? Is there any integration that you use the belt for? For example, would you have someone do the 90-90, wall breathing or any of the lifts or any of that with that on?
So what's interesting is that even though both approaches talk about the diaphragm, they look at how they ultimately get to the diaphragm a little bit differently. So with PRI, they definitely want to do a lot of repositioning. That's their first thing. They want to reposition that pelvis and that rib cage relationship so that the four diaphragms, the right hemithoracic diaphragm, the left hemithoracic diaphragm, the right hemipelvic diaphragm, and the left hemipelvic diaphragm can work optimally. So in that regard, I'm still working on trying to figure out how to make the jump between the two. And the question that I'm playing with right now is, does PRI repositioning help or enhance IAP? I don't know yet. I think it should, but just because I think it should doesn't mean that that's actually going to be the case.
Gotta prove it.
Right, gotta prove it, right? So, so that's where I'm playing with on that right now. But, from the PRI perspective, if I have someone come in and they're absolutely patterned, I'm going to go ahead and try to do some of that. Once again, it depends on what their complaints are.
Okay, sweet, man. That was great. That makes a lot of sense. I do love this tool too.
Yeah, it's great.
Yeah, it's such a good learning curve.
Oh, it basically cuts.
It just takes it away.
Yeah, I mean, if you ever get a chance to just talk to Erin about it, she'll tell you, for years she just kept on telling herself, I wish I had a tool that can just do this for me.
Yeah. Would you have someone doing any of these DNS kind of side planks or any transitions with this on?
All the time.
Yeah,
you
almost you wouldn't without it, right?
Because basically, really, yeah, you absolutely would, right? And it's really crazy to actually see how far anybody and everybody has to get regressed in order to pull these things off properly.
The other thing to think about is, so I think most people would kind of connect this to a weight.
Right.
Where it becomes more of a stopgap than an actual tool for creating better pressure,
right?
Which is what this is.
Right. So, I'm not I mean, I've worked with a few big weightlifters, and you know, it's interesting in that world that they allow for these artificial devices to come into play, like the knee sleeves. And so, I mean, once again, it all depends on what the context is, right? Like there are a lot of things that we do that violate everything that all three systems that we're talking about preach, right? But that's, sometimes you just got to do what you got to do, right?
Yeah.
I mean, I don't think anybody, like if you've ever been to a Cirque du Soleil show, it's like, well, yeah, you shouldn't really be having you know, doing a back bend where your butt's sitting on the back of your head, right?
Yeah.
But if that's what the task calls for.
That's why you need all the tools in the toolbox.
You do. Oh yeah.
Position.
And range control.
Yeah.
Right. Yeah, I mean, and then of course, if we look at everything, if we look at everything from like the length tension standpoint, I mean, all three approaches are looking at it a little differently. Yeah.
Yeah, that was one of the questions I had that I asked you over DM, but like the anterior capsule test for PRI, I think it is, when you're coming down and testing the reactivity or like the end range feel of the capsule. Do you know what I'm talking about?
Oh, the
Almost
extension
like,
drop test?
Yeah. I thought that was interesting where it was like the test, when I saw it done, was cued to relax. But then when you're cueing to relax, you're waiting for the capsule to bounce back. But if I had control over it and I was truly relaxing it through its whole, and I had the ability to relax it through the full range of motion, why would it bounce back?
So you're basically asking, in the extension drop test.
Yeah. So I'm in from flexion and I drop off the end of the table into there. The optimal outcome is for the capsule to bounce back and pull me back up, right?
Yeah, so just to clarify, the extension drop test in PRI is effectively the same as what most PTs would understand as the Thomas test, right? The Thomas test is a hip flexor length test.
Yeah.
And then in PRI, they call it an extension drop test, and really what they're checking for in PRI is the integrity of that anterior hip joint capsule.
That's what they said. Yeah, that's the wording. So what's the difference between that, though? Like, what outcome am I looking for there?
So from a PRI perspective, they do not want the back of your leg to hit the table, right? If you look at it from the lens of the Thomas test, they're going to say, hey, that's a tight hip flexor, right? If you look at it from the lens of PRI, they're going to say that's what's called a positive, meaning it has a restriction, a positive extension drop test, and they would consider that a good thing. If you have a negative extension drop test, which means the back of your leg hits the table, they would consider that undesired range. And then, of course, if you look at it from the traditional PT lens of the Thomas test, it'd be like, oh, your hip flexors are good, at least from that perspective. Because in the Thomas test, you can also, they teach it where you can do it with a straight leg, right, so as to bias the short hip flexors, and then, of course, once you get to the bottom, you bend the knee to pull on rectus.
So, and then from after.
Right, but the FRA assessment of hip extension is prone.
That's true. Yeah, and it is passive, I guess, because you are kind of using gravity to assist that extension.
Yeah. So, so those are how the.
That's a good example of how they all kind of look at one thing, though.
Yeah, I mean, and then of course, I mean, from a PRI perspective, the adduction drop test, which is, I always will just joke around in parentheses and call it not an Ober's test, right?
Yeah.
So.
Yeah. Makes sense.